Hi everyone, and welcome to the National Council's Coffee Break webinar, Master's Level Sustaining Open Access. My name is Joy, and I will serve as your moderator today. Before I introduce Annie Jensen from MTM, I'd like to draw your attention to some important webinar logistics. Today's webinar is being recorded, and you are currently in listen-only mode. If you're listening on your phone, please enter on your telephone keypad the audio pin from the control panel on the right-hand side of your screen. You may send us questions at any time during the webinar just by simply typing it into the dialog box to the right of your screen. Depending on the question, I'll either answer you back or save it to the end and allow Annie to answer it. We'll answer as many of your questions as time allows. Within 48 hours, an audio version and the slides of the entire webinar will be available on the nationalcouncil.org webinar archives page. If at any point during the webinar you experience technical difficulties, please call Citrix Tech Support at 888-259-8414. And with that, I'll turn it over to Annie. Annie?
Thank you, Joy, and thank you to the National Council for hosting this webinar today. Good afternoon, everybody. My name is Annie Jensen. I'm a consultant with MTM Services. And today, our webinar is a second of a two-part series. So hopefully a lot of you had the opportunity several weeks ago to join Joy Fruth with MTM Services, who presented on strategies for developing a successful same-day access model. Today, what we're going to spend some time talking about is how to ensure timely access can be sustained through the whole system. So not just at the front door as far as the intake process, but looking at sustaining it through all the different steps and processes to accessing services. As you know, certainly what we are talking about is a much larger topic around system change in general, and the opportunity today is really to just give you that 1,000-foot view of a few of the strategies that can be used to gain efficiency throughout your system. Next slide. So why is this important? We know that certainly through the healthcare reform that we have had to start to make a lot of changes. Some of those changes being, one of them being accessible to all needed services. So that's, again, not just about making sure there's fast access to the intake, but making sure that all the different services that are identified as appropriate for an individual, they have access to in a timely manner. Secondly, around our services being efficient. So can we demonstrate that we're providing the highest quality service, demonstrating the best outcomes at the lowest cost? And as we move into 2018, we know how critical that's going to be with the requirement for measurement-based care. Thirdly, when we talk about electronic health records, do we now have the ability yet to be able to connect and communicate with other providers within our network of systems through a platform, knowing that that saves us a lot of time versus a way of passing records around through fax, through mail, etc. Fourthly, around an episode of need. So we are now moving into a time where we are not able to just continue an ongoing volume of services for an individual. We really need to be providing an episode of need based on the current impairment that has brought an individual in for services. And lastly, being able to produce our outcomes. So again, moving from our volume of care to value of care and into measurement-based care, making sure that we effectively engage consumers and their natural supports into the treatment process, assisting consumers in being able to manage their own wellness and recovery. And certainly through all of those, what we're going to see from that is being able to greatly reduce the need for high-cost services when we have individuals engaged and we have natural supports as part of that process. Next slide. So today what we're going to spend our time talking about is 3 strategies that we know can improve access through the full service delivery model. And one of those being no-show management. The second one being centralized scheduling, and the third one being levels of care guidelines. Next slide. So when we talk about the primary challenge that is facing all healthcare providers today, be it behavioral health care, be it physical health care providers, integrated health care providers, it is capacity. And when we start to look at managing capacity and ensuring timely access through the whole system of care, it becomes even more challenging. And so we're going to talk about the capacity at the 3 different levels today. Next slide. Those 3 levels being primary access. Primary access is your wait time from an individual calling for services, or if they walk in for assistance, to the point in time when the intake and assessment is completed. That is really where the webinar several weeks ago with Joy focused on. How do we ensure timely access to starting services for an individual? Well, we're going to talk some about today is secondary and tertiary access. So when we look at secondary access, what we're looking at is the wait time after the intake has been completed to the next appointment with a treating clinician. When we talk about tertiary access, what we're looking at is the wait time from the intake until the psychiatric services. Next slide. So through this process, when we think about an individual seeking care and going through the process of an intake, then meeting their primary clinician, then meeting maybe the individual that's going to be providing their psychiatric medication services to them, and all the different steps they go through with this, there are 2 main deterrents for an individual to begin services. And one of those is around the wait time from the initial contact until the assessment. So if an individual calls for services and there is a delay until they can get in to have that intake and assessment completed, we know that that increases the no-show and cancellation rates for intakes, ultimately resulting in an individual potentially not coming into services that needed those services. The second place that this happens is if we start to see where there are multiple face-to-face intakes and assessment sessions for an individual before they can start their open active care with their providers, it tends to increase the no-show levels. As we think about this, as far as a lot of times what we see from a national perspective is we have a lot of different barriers and appointments set up for an individual before they can come in and start ongoing treatment. A good example is sometimes we set up a process with very good intentions around individuals coming in to do pre-registration paperwork, attendant orientation. But when we step back and look at that, what is that really doing? What we're really doing is scheduling an appointment and creating an appointment for individuals to come in only to schedule another appointment to start their services. So we can see how that can quickly build for individuals to where we start getting multiple face-to-face appointments before treatment begins. And the last thing that I just want everybody to keep in mind is the feedback that we hear from consumers seeking services is when we ask questions, what the consumers indicate is that they feel like they're helping us. They feel like they're helping us complete our requirements to get them into services. But when we listen, they indicate that we are helping them. So through this process, something that becomes so critical is that we try to streamline it. We streamline it by reducing the number of questions we ask to the minimum that are required, in addition to reducing the number of appointments where we are asking them a lot of questions. Next slide. So with no-show management, first thing critical to the success of no-show management is we must change our behavior, shifting from having a schedule to managing a schedule. So what we're going to talk about through the next several slides is how do we really start to take ownership of the schedule and manage it, and what are the different ways that we can do some no-show management techniques both with the consumers but also holding ourselves to the same level of accountability. Next slide. So I give you some questions that I hope that you were able to, 1, answer, and 2, take back and that you would be able to pose to anybody in your organization and they would be able to answer these questions. The first one being, from a clinician's perspective, are the caseloads in your organization full at this time? And what you're looking at is you're looking at a webinar that was done back in 2009 with David Lloyd, the founder of MTM Services, when he posed these questions through a poll. And these were the answers that he got with these questions, with the first one being 70% reported that the caseloads are full in their organization at this time, 30% reporting no. One of the questions that I would ask you about that also is, I think sometimes what we also have is we have full as a perceived full. So certainly we're full. However, how many of those consumers on the caseload are active, non-active consumers? Meaning they're still open as a consumer within our organization, but they are non-active in the sense of they are not currently engaged in treatment and attending treatment. So when we count our caseload, certainly they increase the number on our caseload. It looks like we have a very large caseload number. But one of the things we need to keep in mind is how many of those individuals are actively engaged with us at this time. Secondly, do you know the cost in days of wait for your organization first call to treatment plan completion? So that is not just through the intake process for some organizations. That could potentially be 2, 3, or 4 visits to complete the treatment plan. The goal being, for those of you that attended with Joy, that when somebody comes into open access, the intake and a treatment plan is completed at that appointment. However, some organizations have it structured differently. So do you know the days for an individual as they go through that full process until the treatment plan is completed? Thirdly, indicating a no-show cancellation percentage last quarter in your organization for intake and assessment appointments. So what was our no-show and cancellation for individuals that called to get into services? You can certainly see there the highest numbers between 20 and 30%, 42% of individuals did not show for those appointments. Between 40 to 59%, we had 16 organizations showing that. So between the 20 and 30% and the 40 and 59%, you can certainly see the number of organizations that are experiencing that number of no-shows. You can also see the number of organizations that were not aware of their percentage. And when you look at that 22%, we're not able to report what the no-show percentage was. And lastly, can you indicate the no-show and cancellation percentage last quarter in your organization for individual therapy appointments? So that's really looking at past the intake process when somebody is involved in ongoing therapy services. What is the rate of cancellations and no-shows? And again, 49% of the organizations reported it's anywhere between 20 to 39%. 25% of the organizations presented between 0 to 19%. And you can see again, 26% of organizations were not aware of that percentage. That becomes really important as you start to move forward with effective no-show management, that you can answer those questions. Next slide. So how much capacity is lost in your no-shows? Again, what is your organization's no-show rate for return appointments? And the next question then for you would be, how much additional capacity would you have in your organization if the no-show rate was below 10% for all service types? So if you can currently answer the questions that we just went through and the one at the top of this slide, and let's say that you have a 30% no-show rate for your return appointments, and we can get that down to 10%. You have just gained an additional capacity of 20%. So that's one of the first things that we look at through this process is, what is your baseline? What's your current no-show percentage? And then if we can reduce that, how much capacity do we gain? Additionally, how much capacity would you be able to gain if your organization was able to successfully backfill 90% of canceled appointments? So when we talk about backfilling appointments, what we're referring to is if an individual cancels an appointment, how often does that appointment remain open versus going in and finding an individual that needs to be seen sooner or is waiting and filling that appointment time? Next slide. First step as we think about effective no-show management, it's very important that we can distinguish a no-show from a cancellation. So as you're either developing or enhancing your no-show policy, some of the things that you want to be thinking about with this. Do you have a no-show defined? And as we talk about a definition of a no-show, typically what we look at is that they did not give 24 hours notification. Okay, so it's less than 24 hours. When we look at cancellations, two types of cancellations that people tend to want to track. One of those is cancellations rescheduled. With that, that means that an individual did call 24 hours before the appointment or longer, and that they did reschedule for a later time. A no-show not rescheduled is that an individual called in over 24 hours before their appointment, but they did not want to be rescheduled at this time. Important is for the clinician, we want to be able to know that the individual didn't reschedule and be able to follow up on that. And lastly, around a provider cancellation, did the clinician cancel the appointment? So as we talked about a couple of minutes ago around the accountability is not just on the consumer, it's also on us, and we have to hold ourselves accountable at the same percentage and rate that we would hold anybody else accountable. And if we keep appointments, what we know is that our consumers start to show less and less for the appointments also. Next slide. So responding to missed appointments. What we're going to talk about is being proactive after each missed appointment to make sure that we can intervene at that point in time and try to reduce that behavior of missing appointments. So after each missed appointment, one of the things that we want to start to do is intervene with the consumer around what are the barriers to attending that appointment and being able to show for that appointment. And in a minute, what I'm going to show you is an example of that. So after each missed appointment, we want to intervene to assess the current barriers. But what we also want to be able to do is we want to be able to have alternatives for once there is a pattern. So what are some of the policy triggers for a pattern? A pattern might be when an individual's rate of a no-show or late cancellation, meaning it was less than 24 hours, exceeds 20% or 2 over a 90-day period. Or it could be you start to look at 2 consecutive no-shows or cancellations. Or that the rate of cancellation exceeds 30% or 3 over a 90-day period. At that point, you might decide that you're not going to do any further routine appointments. You're going to send a 10-day letter and put them into an alternative scheduling plan. So after each missed appointment, we want to be proactive and address the barriers. Next slide. So this is an example of a barriers assessment for after the first missed appointment. When they return back in to see you the next time into services, doing something like this doesn't take much time, but what it does do is it really starts to reestablish around how the time is valuable, how you value the time, they need to value the time, but at the same time we want to make sure there aren't things getting in the way of them being able to attend their appointments. So you're looking at things like, are these services important to their recovery? Asking them these questions. What are the most important goals that they want to achieve in services? Maybe it's that what they want to achieve and what we think they want to achieve is different. Certainly checking in with them around, do they have any concerns about the services they're receiving? Is maybe not a good match between them and the clinician? Did they maybe think they were going to be receiving something different in that service? Or are they having a barrier to attending their appointments, such as transportation, child care, conflicting appointments? Do we always put it on the same day that they have another routine appointment each week? And then what are going to be the action steps taken to address that barrier? And then at that point, it's both the consumer and the provider signing off on that they've made an agreement to work through that barrier and come up with any solutions. Next slide. So then the next thing that we saw a couple slides ago is not after one missed appointment, but after we start to see multiple missed appointments. It could be 2 over 90 days. It could be 2 in a row. It could be that they've missed 3 over a 90-day period and we've sent them a letter. What we want to start to do is identify options for alternative scheduling. So certainly what we want to start to look at with that is, do we have groups? Do we have a walk-in clinic for them? Can we start to send them into same-day appointments in the sense of that they can call each day to see if there's been any cancellations? Do we start to look at some alternatives around scheduling them during off-peak hours? So after we've started to identify a pattern of no-shows and we know that 4 o'clock is a coveted time for consumers, we want to make sure that we're providing that to individuals that are attending all their appointments. Starting to look at some of those off-peak hours. Certainly in community behavioral health, we are the safety net for all individuals, and just discharging individuals isn't the answer. It's really starting to look at how do we start to identify alternative scheduling options that individuals can go into. Next slide. So in addition to being able to offer some options for the consumers, we want to make sure we're proactive in reducing our exposure to failed appointments. So some of the strategies with that is that we only offer a limited number of sessions. We don't have them scheduling out 6, 7, 8, 9, 10 sessions. When we're developing their individualized service plan and their treatment plan, what we want to do is we want to let them know that they're in for an episode of need. This is limited, and that we're going to value each and every appointment that we have together. Also, for individuals who are either stable or that a clinician has identified might not be able to be successful in a full 45 to 60-minute appointment, shortening the service contact time to 15 to 30 minutes for an individual. Also negotiating the next appointment. When ending an appointment, asking when they would like to meet again versus just assuming that they want to come back the next week. Maintaining a backfill list, and that's what we talked about earlier around being able to backfill appointments. So we want to make sure that we have a list of individuals that need to be seen sooner that can be contacted on short notice to maybe potentially take an appointment. And then promoting group services. It is valuable, it's less expensive, and it certainly can be an alternative on the front end for individuals getting engaged in care. It also can be an alternative as you start to move individuals into a lesser level of care to where they can move from individual therapy into group services. Next slide. One of the next options is centralized scheduling. So we just talked about some strategies for no-show management to improve our capacity and gain capacity. The second area is centralized scheduling. And as we look for ways to gain efficiencies, very often what we find is that the clinicians' roles include tasks that take away from their direct service time to be able to provide the services that they are skilled at doing. And one of those is centralized scheduling. So when we start to look at clinicians that manage their own schedule, what we find from some of the national data that was collected on this is that on average they spend 100 hours a year managing their schedule. And sometimes it's hard to believe when you hear that number, but when you think about spending a couple minutes to schedule everybody, then when somebody can't come and they call, well, clinicians aren't typically available, so a message is left, we call them back, they might not be available. The phone tag, the multiple contacts that go into the back and forth, that's what it tends to add up to in a year. When we think about being able to put a back into their schedule for direct service, that is a lot of capacity per clinician. And the key concept really is that the schedules belong to the organization, not the provider. They're not in private practice, they work for an organization. And the organization is going to hold the staff and consumers accountable for those appointments. Next slide. So when we talk about centralized scheduling, a couple of critical points to this is we're building a template for each staff member. Typically what we like to see is that that template is only built for a 90-day period. What does that also help avoid? It helps avoid those vacations, the things that are planned out that clinicians certainly need and are going to take and we want to encourage. However, what we don't want to do is be bumping a whole bunch of consumers that are already into the schedule. So when we aren't booking out 4, 5, 6 months, it gives the flexibility to be able to change schedules. Certainly also we want to make sure that we're blocking out for supervision, team meetings, lunch, certainly if they're working into the evening, their dinner breaks, holidays, trainings. Again, what does that do? It gets the schedule so that we aren't tending to move consumers around when things come up, but we've already identified the standard things that we need to protect time for. Lastly, though, it gives you the ability to build a template that needs to be sufficient enough to absorb the no-show rate. So it's a way to incentivize the clinicians to where, based on their current no-show rate, you're going to be able to build a schedule based on how many hours they need to be seeing consumers each day. Next slide. So the other perks to the centralized scheduling is, certainly we know that one of the things that it does is it allows support services who will be doing the centralized scheduling. One, they're going to be completing the functions of scheduling new and return appointments, taking that off of the clinician. Also around, they're going to be able to manage the backfilling of appointment times. So when there is a cancellation and clinicians are tied up in their sessions, this gives an individual where their job is to be managing those schedules the ability to, at point in time, start to identify somebody that might be able to come in that canceled slot. Also, they'll be completing the confirmation phone calls, not reminder phone calls, but confirmation phone calls, making sure that individuals are planning on coming to their appointment. If we do this 48 or 72 hours in advance, we can identify individuals that there's now been a conflict for them and they say, I'm not able to come. That gives us up to 72 hours to fill that appointment slot. And certainly one of the things that we know is a great benefit to this is they are an available contact to that consumer when they need something at any point. We know how frustrating it would be for us if we needed to change an appointment time and we kept getting voicemail because somebody was busy and they had to keep calling us back and we kept missing them. This way, they're calling somebody that's their task, they're available, they're able to take that call at any point and be able to reschedule the individual and meet their needs at that time. Next slide. And lastly, what we're going to talk about for just a couple minutes is levels of care. So when we start to talk about levels of care, again, this is around setting an episode of need. And when individuals come in that front door through open access, we want to establish their level of care at that point. And their level of care is really going to determine for them the scope of services they're going to get. It's also going to start to talk about the frequency, the intensity, and the recommended length of time. Next slide. So one of the things that becomes really important is that you have some tool that's able to identify their level of functioning. Certainly we know with medical necessity the requirement now to be able to demonstrate functional impairments and how it's impacting somebody in their daily life functioning. That's the first thing that happens. Then that's going to drive their level of care, which is going to be tied to their length of stay, which is going to appropriately match them to the services that they need. So again, we're talking about frequency, we're talking about duration, we're talking about intensity of services. But something needs to make that decision for us to where we can start to demonstrate through inter-rater reliability the level of care that an individual is going into. Next slide. So with our levels of care, we're going to establish our baseline measurement. Then what happens is, again, we're going to use one of our standardized tools. Lots of different tools out there, listed some examples for you in the slides. They're going to help you establish the baseline functioning of each individual coming into care. Then we're going to use that to assess the appropriate level of need. Slide. Each level is going to include some of the following. One of the things that happen is, what is the admission criteria for that level of care? So we want to look at the indicators for that level of care. And that would be based on the tool that you decide to use. So you're starting to define, based on the outcome of that tool and the results for that individual, the admission criteria. Then we're going to start to look at the descriptors of the functional impairments to meet that level of care. For an individual in that level of care, what do we typically see around the current functional impairments they might be experiencing? And then from there, we're going to be defining the length of service, which is typically going to be your range of the length of time in services. And then what are the types of services that are going to be offered? What we're really looking at in our levels of care is a menu of services. Maybe not that every individual needs every service in that level of care, but that we have a menu that we can pick from for the most appropriate services for that individual so that we can have individualized care. And then we're going to be looking at episode of care, so the frequency of each type of service and the intensity of each type of services. And then are there going to be any add-on services for that individual that we've decided they would benefit from? And what are going to be our measurable discharge criteria for that individual? Next slide. So what you're looking at here is an example. And this is just an example of levels of care. What you can start to see is exactly what we just went through. What are some of the indicators, looking at different tools that are out there? And then what we start to look at is what is the recommended length of time in services? And then what are the menu of services that that individual could potentially receive? And then it's broken down for each type of service, the amount. And then you can see that there are the possible descriptors for an individual that is in that level of care, and certainly transition or discharge criteria. Some individuals might stabilize to where we're ready to discharge them. Some individuals, depending on their level of care, we might be looking towards a transition to a lesser level of care. And so this is one example that you'll have, as Joy referenced, around having access to the slides within 48 hours. And with that, I want to thank you very much for attending the webinar and hope that you found it beneficial. Tried to add a couple resources in for you, as knowing that this is a 30-minute webinar and just kind of that 1,000-foot view. And with that, I'm going to turn it back to Joy.
Thanks, Annie. I appreciate that. So it does look like we have time for a couple questions, so I'm going to ask one, and then, like Annie said, you have her contact information, and I know she would encourage follow-up questions and moving forward on any services that she can provide you. So one question that came in is, in regards to centralized scheduling, challenges that our agency have been around moving this to a clinician, moving to clinician to admin staff. With 600 plus clients, what is your recommendation in terms of how many admin staff is needed?
So that's a great question. And unfortunately, I'm not going to be able to answer that as far as giving you an identified number, because one of the things that you want to look at is what other things and roles will that individual have and responsibilities within your organization. So if we talk about the administrative staff taking over this role, will they also be responsible for checking people in? Will they also be responsible for checking people out? So one of the things that becomes really important through this process is that you start to look at and be able to break out and define roles for each of those individuals. And if one of their primary roles is going to be scheduling individuals for new appointments, scheduling them when they are leaving out of a session, and certainly being the point person for anytime anybody needs to reschedule, then I would ask, are they also going to be doing all the backfilling? And what are their other job duties? But it's a great question, in that a lot of times what we see is where sometimes we fall short in our staffing tend to be the administrative staff, because they don't directly generate the revenue. But what we do know is they are critical to running an effective organization that way. So first steps for you through that would be to start to look at and assess the other roles that they're going to have in addition to that. Understanding that based on the number of clinicians and clients that will be seen through that, you might need to have a dedicated person depending on the roles that they're going to have.
Great. Thank you, Annie. Well, thank you, everyone, again for joining us today. As I said, the slides and the recording of this will be available on our webinar archives page within the next 2 days, and that will include Annie's contact information. So thank you again for joining, and I hope everyone has a lovely afternoon.
Thank you.